What is up, everybody? All right. So, thanks everybody for giving the feedback and whatnot today on the throughout the various social media platforms about your comments about today's case study. So, trying out something a little bit different to doing our lives in the evening as opposed to generally Friday afternoons. So, just trying to toss it out and give everybody a few more options. All right. I'll bring up the comments. So if everybody watching, wherever you're watching this stream from, feel free to hop into the comments if you got any questions or feedback as we go through this. And then I'll kind of be keeping an eye on the comment box coming up and then try to pose any or give any answers, any questions you all may have. So let's get into it. So in the scenario, you were dispatched to a residential home for a fall. Dispatch advised you that the patient was an 80-year-old female who fell from standing and is complaining of neck pain. You find the patient sitting on the floor with her assisted walker nearby. She has a GCS of 4, 5, and 6. Her airway was patent. Her breathing was normal. She's speaking in full sentences. Skin was warm and dry. And the only disability you noted was just she's just globally weak. She's a frail geriatric patient, just globally weak. Then a secondary assessment, BP 136 over 76. Put the pulse ox on. She's 98% on room air. Heart rate's 80 and regular. Blood glucose is within normal ranges. Brisk capillary refill. And she's afebrile. Then at assessment, you just find she has spinal tenderness and pain with range of motion to the cervical region and also some lumbar pain. While she states she does have some chronic pain, that this is all abnormal and very much acute. In conversations with her, she just stated she became off balance while she was traversing through her house with her walker. And again, only complaining of pain localized to the neck and the lower back. She has past medical history of hypertension, heart disease, and osteoporosis, which that osteoporosis was the underlying cause, which has ended up resulting in her weakness and requiring a walker to get about. Physical exam, lungs were clear and equal. Her skin's warm and dry. Musculoskeletal, other than the neck and the back, everything else is unremarkable. So pelvis is stable, PMS is intact, all those good fun things. All right, so you were posed with these questions. What are your concerns? What's the likelihood of this being a serious injury? And what would be your plan of care? So I posed around the different platforms today and read some of the comments, and it seemed pretty consistent that everybody was, kind of worried about spinal precautions. So I think most conversations involve putting a C collar on, focusing on there, doing 12 leads, a lot of comments about trying to detect maybe why she fell, just kind of globalized standard of care. So with this, it's kind of more of a basic concept for an understanding of, kind of a sensitive population of the geriatrics. We run numerous geriatric calls. It's even estimated by, the year of 2050 that 25% of, the world's population is going to be the geriatric population over 65. Okay, so in this, big things is detect and inspect. So I know I advocate a lot about just doing detective work, but that's paramount in these type of things. Advocate for the patient, and we're trying to establish a baseline because in the case study preview talked about that does have some chronic pain, but what is acute and what's chronic or what's an exacerbation of those chronic conditions. So one thing to think about with the geriatric populations is once they hit that age of 65 and they're starting to have, osteoarthritis, osteoporosis, and just overall getting more brittle bones. They are way more susceptible to low impact causing significant trauma as opposed to the adult population. All right, so this was a study that came out that was kind of a retrospective study on patients and who had fallen from standing, being the white bars, or high energy impacts like a motor vehicle accident. So if you look here of the relation of where these fractures are occurring, so C0, that's meaning like the occipital region of kind of the attachment points for tendons and ligaments, whatnot in the neck. Any damage there at C0, atlas in your axis, all the way through all your cervical vertebrae. We can see that kind of inverted correlation happening to where low impact is having high correlations with um, your upper cervical vertebrae fracture. So in these patients who are falling from standing and just falling right on their bum, there is a high correlation with them obtaining, or not requiring, but resulting in cervical fractures, just fall from standing. But then when it gets into more high energy, you're getting higher prevalence in those lower cervical vertebrae, more from the whiplash as opposed to a compression fraction. So that compression mostly coming up here, resulting from the fall. And there's a lot of mixed research, but all of them give definitive ranges of those patients over the age of 65. If they're complaining of neck pain, spinal tenderness, that there's a huge correlation with them actually having cervical fractures. Okay, so keeping that in mind, that we've had, we think about, well, there's not really much mechanism of injury there. We've used this phrase mechanism of injury so much, and it's not always true. We got to think about those underlying things. So in that geriatric population, fall from standing, having neck pain, there's a pretty decent probability they could actually have spinal fractures. So if we think about that spinal column, and as a normal adult head weighs approximately 5 kilograms. So skull, muscles, hair, brain, everything intact. 5 kilograms, 11 pounds roughly on that spine. So we take that geriatric patient and they fell from standing and they go straight down and they fall right on their bum. That's 11 pounds of compression on those vertebrae. Now, if we're thinking about these high vertebrae, C1, 2, and 3, C1 and 2 are the least, let's say, least stable. So they're the ones that manipulate the most and move around. So they have the highest correlation of developing fractures from those compressions, because ultimately some of those vertebrae are, simply being the most used and kind of getting the most wore out. So just imagine that, they have spinal settlement in here. As you get older, you shrink. So all the disc spacing in here is not as good. So once those discs start to wear away and that spine is actually compressing just over age, there's a lot less absorption that spine can take. So, you imagine you got a brand new vehicle and you go over that speed bump and that suspension feels so nice. Now you put 300,000 miles on that same vehicle and you hit a speed bump and it jars and beats you around because the suspension and everything has lost a lot of its cushion. Same things with that spine. Those discs wear out, the spine compresses, and it can just end up causing a higher resulting force compressing down on that spine. And then when you take into consideration of different postures and other things affecting these patients as they get older, more effects of kyphosis. Okay, so kyphosis being that change in the posture and kind of that arching of the upper spine. So if we take, normal, perfect posture, compressing down, 5 kilograms, that's 5 kilograms of force compressing down. But now if we've changed out this angle here, they have that protruding neck from kyphosis. That's quite a leverage point from that head. So if that leverage from 5 kilograms has compressed down more, that ends up being 20 pounds of force put out. And that's just by, simple physics stuff. So 45 degrees of angle, 5 kilograms being pushed down is actually 20 kilograms of force being compressed down on that spine. So, now imagine that you throw in those other things of osteoporosis and just, kind of chronic issues of how much that resultant force is going to be down on that, you know, simply definitely used spine. Another thing we need to be considering is in that geriatric population is cerebral atrophy. Basically, their brain shrinks and loses density as they get older. Okay, so there's a couple different images here. So we can see, skull cavity basically completely full of a brain, your midbrain, um, cerebellum, and then you can start to see this atrophy. Okay, even the spacing from those faux lines. Okay, and they are much more definitive than here. So this brain, very dense here, atrophied, brittled out there. Okay, now where that's really going to come into play, considering these geriatric patients with that atrophy, is, you know, again, normal adult, the brain occupies about 80% of the skull's cavity. Okay, the rest of it is generally cerebral spinal fluid. Well, then as they get older, you have that brain atrophy, you may be down here to 60%. Okay, just for rough numbers. So if you've had this, and say now we've sprung a leak, so they've got a little brain bleed in an adult. Well, it doesn't take as much blood here to occupy that 10% of the remaining space to start causing symptoms of herniation, such as that increasing hypertension, bradycardia, and ataxic respirations, developing that Cushing's response. Okay, now imagine over here how much more room we have for blood and other fluid to accumulate. So any type of encephalopathy could be developing, and you're going to be a little bit longer into the process before you're really starting to see some outward signs of these patients. Whereas an adult, if they're bleeding at the same rate, this space is going to occupy and be pushing on the brain much quicker than this side will. And then we also take into, the thoughts of what their baseline is. If, we're considering an altered mental status, or they have high blood pressure from a potential brain injury, of trying to figure out what's chronic and what's acute in these patients. Okay, so for management, and this is, C-spine immobilization. If they have neck pain, we need to immobilize that spine. With C-collars, we know that, with a lot of research and stuff, there's different variations and different discussions going on currently about C-collars, whether they actually do more harm than they do good. The big thing is we want to aim for comfort. Okay, so if we're putting this on and it's restricting their airway or it's causing them more pain, it's not doing us any good. Where then maybe we could just go down here to some simple soft padding. We can modify, shape up some towels or sheets or blankets where we got, just to try to help pad the voids, keep it all up. And then if we also start thinking about, if we've got them in that semi-Fowler spot on our cot, and they have this huge kyphosis and their neck is significantly protruded, of how we're going to pad them to keep spinal motion restriction in play with them on the cot. So it's, taking this padding and just fill all those voids. Okay, so the big thing is we're just wanting to keep that spine in line, prevent any side-to-side forward motion and manipulation of those, possible broken vertebrae. All right, look at this race. There we go. All right, so some other things we need to be considering with these patients is, are they on any type of blood thinners? Again, with the compression of that spine, if it's enough to compress the spine and possibly cause, cervical fracture, we also think about the jar effect of that brain, the atrophy of it, and it's got more room to shake about, if you will. Okay, so if they're on any type of blood thinners, again, there's a high correlation of these patients who fell from standing and sustained brain bleeds just from the hit, the jar, and the coup and contra coup effect of that brain in the skull cavity. And with osteoporosis, it makes them way more susceptible with their advanced age and their advanced medical issues for the likelihood of those fractures to develop. And then again, what is acute and what's chronic? And then we think about in these conditions here that if they do have osteoporosis, they may be on, continual pain medicine. They might be on oxycodones chronically for their osteoporosis. So that sensation of pain might be blocked from, the oxycodone and the stuff that they're on chronically. Okay, so even just that mild discomfort we need to treat as, a possible significant acute complication, spinal motion restriction, and, padding the voids and just ultimately making them comfortable. So thanks for everybody's feedback in there today. Just remembering, it's kind of once they're hitting that advanced age, they start having other medical complications such as osteoporosis, that they have a much more greater likelihood for developing intracranial hemorrhaging, cervical fractures, even from those low impact. Okay, so remember, mechanism of injury is not always everything. We really got to do that detective work to try to truly assess our patients. Thanks everybody for tuning in. Thanks for everybody's engagement throughout the day. Everybody take care.